Our session ends now with a mini seminar by BD on B3 lesions and the classification system, which will be presented by Dr. Liat Malek, who's a radiologist who's been practicing exclusively in breast imaging since 2015, and by Dr. Kirstin Fearnhead, who's a histopathologist in private practice since May 2018, and she has a particular active interest in dermatopathology, breast, placental, gastroenterological, hepatobiliary pathology.
So I'd like to just start by a show of hands with a question of who is familiar with the B classification of breast lesions. Okay, I think it's a minority.
And I also wonder whether you think the B classification is the same as the BI-RADS classification. Okay.
And don't be shy, because when I first saw the email coming through about discussing B3 lesions, I thought it was BI-RADS 3. Okay, so in fact, the B classification, the B stands for biopsy, is a classification that's used a lot in the UK and Europe. And it stands for, it basically delineates 5 categories of findings on needle core biopsy. So B1 is normal tissue or a non-diagnostic biopsy. B2 is a benign lesion. The B3 lesions are the ones that cause the most concern and contention, and these are lesions that are regarded as being of uncertain malignant potential. The B4 lesions are suspicious for malignancy, and B5 lesions are classified as malignant. So the purpose of the panel discussion today is, in fact, to discuss how we are managing B3 lesions, atypical lesions, and how we should be managing them. So if we just go through what the B3 category encompasses, it starts with what is called in the UK atypical intraductal epithelial proliferation, or AIDEP, and that's largely what we would call atypical ductal hyperplasia, or ADH. They have a slightly different viewpoint on whether or not you can call ADH in a needle core or if you need a larger piece of tissue. Then there's lobular neoplasia, which has to be classic, so not pleomorphic, non-mass forming, and no chemotonecrosis. Flat epithelial atypia, radial scar/complex sclerosing lesion, the difference there just being the size. Papillary lesions, important there, we need to know if there is or is not atypia. Cellular fibroepithelial lesions, which are the ones on core where we're not quite certain if they're a fibroadenoma or a Phyllodes tumor. Mucocele-like lesions, and a mixed basket of others.
So B3 lesions get diagnosed on what we do a core biopsy on the patient. But then what happens going forward with the patient in terms of their management? So usually we have the classic pathway of the surgical management, and I'd like to invite Francois to discuss that. Or we would observe these patients more closely, so we would bring them back for follow-up more regularly. From the radiological perspective. Francois, how do you normally manage these patients?
Listen, I'm here as the expert, but I mean definitely no expert on this. Firstly, to say that this is a problem of screening. So I agree with Justice that screening 70% of the population. So actually we don't do any screening in this country because there's no ways that we're screening 70% of our population or doing regular mammograms on 70% of our population, but we do see this, and I think it's important that people identify it and know what to do with it when we do encounter it. And traditionally, these patients were sent to the surgeon, and they either knew a little bit about it or not about it, and often it was discussed in the MDTs, but most of these patients ended up having an excision biopsy. And because they are all by and large, non-palpable lesions detected on screening or mammograms that will be done for patients. Maybe they had mastalgia or some breast symptom, but usually they don't have a lump in their breast. We would take them to theatre, and then we would do an excision biopsy by some form of localization, whatever you as surgeon use. Mostly in this country it would be wires, but there are new technologies available that people use to then excise these lesions. And that's basically what we did for a long time. But there's newer things coming through now where we should maybe rethink that situation, and I think that's why we're having this discussion. First of all, you need to know what it is, and then you need to sort of, in your MDT, decide what are you going to use when you encounter these conditions.
So the issue with the B3 lesions is that they've got an upgrade rate of anywhere between 13 and 35%, which is quite high. And so what is happening, particularly in the UK and Europe, is that they've started implementing the use of vacuum-assisted biopsy. They call it vacuum-assisted excision in this case, simply because they're taking a larger sample of the lesion at hand. If the lesion is small enough, they would even try and remove most of the lesion if it's less than 15 millimeters. And that is not as a therapeutic procedure, but it's simply to try and get a more representative sample so that we would know whether there is indeed upgrade in the lesion or not. And then, of course, this all gets discussed in a multidisciplinary meeting, and then the final decision gets decided then.
So most of the lesions in a lot of the algorithms, certainly from the UK, the next step following the needle core biopsy of a B3 lesion is in fact a VAE, or if we want to use the term extended VAB rather, with the intention not of excising the lesion necessarily, but of basically more sampling. So are there any lesions where we think we should not proceed to a VAE? Maybe Francois.
The ones that they recommend that we shouldn't be doing it is the papillary lesions with atypia specifically. Yeah. And that's why it's very important that in your MDTs, you need to ask the pathologist, and they should report on that routinely, I think, that if there's a papillary lesion being reported, they need to say atypia or no atypia. Because the ones that don't have any atypia, you can excise with these extended VABs. Whereas if there's atypia, an excision specimen is recommended because you really need to look at margins in those lesions.
So the UK guidelines actually specify that the lesions that should be left alone are the papillary lesions with atypia, as you say, the fibroepithelial lesions and sclerosing lesions. The European guidelines are slightly different. They quote the ADH that should be left alone, so we shouldn't go for an extended vacuum-assisted biopsy, again, sclerosing lesions and fibroepithelial lesions. And I think in our context, we see a lot of fibroepithelial lesions, and we need to stay very clear of those lesions when using VAB. We should not be...
We've got a comment from Dimitri.
I'd just like to know, how would a vacuum-assisted biopsy add value over a core biopsy? I mean, what's the difference?
The intention, I think, is to obtain a greater volume of tissue, and the recommended volume is 4 grams. And the intention there is that with more sampling, we can upgrade the ones that potentially should be upgraded to malignancy, and perhaps remain where we are with the other ones and proceed with close follow-up.
Like you'd miss a malignancy in a core biopsy?
You could. And that's because of minimal tissue being taken in a needle core.
Okay. So some of these B3 lesions are heterogeneous. So they may have a malignancy or a DCIS within them, but we haven't sampled that with a core biopsy because it's a much smaller sample. Whereas with a vacuum, we are taking a much larger representation of that lesion, and therefore we're able to. That's why historically these B3 lesions would go for open surgical biopsy. So again, it's a biopsy, it's a diagnostic procedure, not a therapeutic one. If on open surgical biopsy the lesion would be upgraded, then they would go in for definitive surgery. So we're trying to say that there is a place for radiology to come in and prevent the patient from going for a surgical procedure and rather have it done in the office, a vacuum-assisted biopsy.
So how would you then upgrade it to a vacuum-assisted biopsy? Because theoretically then, all of your core biopsies could then be missing a lesion, correct?
Yeah, absolutely. But the B3 lesions particularly are heterogeneous.
Okay.
So,
So just these
so
are the ones
these
that
are
you'd
the
upgrade.
main lesions that give us the problem, that are associated with that kind of wide upgrade variability. So that's why we would stick with these lesions.
Yeah, so I mean, these lesions are mostly picked up as calcifications or asymmetrical density or radial scars or whatever they
Or
call
a,
them.
yeah, or a
Those-
distortion.
Distortion, that is what you see on the mammogram. Then you do a biopsy, then you get one of these things back. Now, is there a cancer or is there not a cancer? Because these are not cancerous, these are benign lesions. All of these things are benign. But if you go and take more tissue, you're going to, in some of these lesions, up to 35, 40% of them, you'll find a cancer there. You're just missing it with your first biopsy. So you need more tissue to exclude that. Now, if you do an excision and wider excision first before you head off to theatre, you're going to save a lot of patients going to theatre, because what you ultimately want is the ones going to theatre, you really, how can I put it? You don't want to take patients unnecessary to theatre. You really want to take them to theatre with really knowing what's going on. And often taking these patients to theatre is to actually get an idea of the margins, because the big downside of doing these big vacuum-assisted excisions on these patients is you don't know what the margins are. So you don't know, okay, now you diagnose a DCIS, which is often the case in these lesions. You can diagnose invasive cancers as well, but often they are upgraded to DCIS, and now you don't know what your margins are, and then you need to go to theatre again. So you want to limit that unnecessary theatre biopsies by getting more tissue initially. That's what it's about.
There's a blinding spotlight in my eye, but I can see Lucy would like to make a comment.
Hi, Kirstin, Liat, Francois, thank you. I agree with you, Francois. I think it's about deciding, what you need to go and chase down and what you can safely observe. Liat, I just want to ask you, we've really been trying in Pretoria to sort of adhere to the guidelines and send the patients off for VAB. Helene's sitting here next to me and she does a lot of that. But we're struggling in terms of funding. We're having problems in terms of the medical aid because they basically just go, well, the patient's already had a call, and why don't you just take them to theatre and go in? So, Liat, from your side, do you have any recommendations for us? How are we going to approach this and how are we going to tackle this?
I think we just have to educate our medical aides. We don't have that much of resistance from the medical aides at my practice, so we are able to perform the VABs following our core biopsies. But I think it's just a matter of us engaging with the medical aides and just showing them the evidence-based medicine. There are a lot of studies that are coming and a lot of guidelines coming from the UK and Europe, and we just need to keep pushing them, really. And especially if you have an MDT, I think that's very important, that your MDT also gets recognised by the medical aid, because when decisions are made in an MDT setting, they take that a lot more seriously.
Thank you.
Okay.
Morning all. My question relates to, it's mainly for the histopath there, Dr. Kirstin. How does this classification deal with apocrine lesions, papillary apocrine lesions? Because atypia is almost a given in those lesions. Do they get separate treatment, or do they all?
I think they fall under AIDEP in the British classification, and they're managed as per that algorithm which does recommend then a VAB.
And what I do find, I don't know about the other histopaths, another complication with apocrine lesions, not just in this setting, is the often lack of myoepithelial cells, which then kind of sends you jittery about whether it's an invasive or even higher grade lesion. How do you deal with that? I mean, I
think maybe depending on your degree of concern, if you're missing MyEps, perhaps it would be more prudent to put it into the B4 category, suspicious for malignancy. Our time is up.
I think there's one more question over there.
Another question?
mostly hematoma, fat necrosis, and not much left of the actual lesion that we're chasing. So is there any guidelines on how long we should wait or an surgical approach after upgrading?
No rush. This is not an emergency. This is a benign lesion. I think you need to explain to that patient, because you have a hematoma, and there's often a big hematoma there. It's a mess operating there. It's not nice. So I would wait 3 months. Just explain to the patient. We found something here. It's not a rush. And even if we find a DCIS there, which is usually what it upgrades to, it's not an invasive cancer. It's not going to spread. Can't kill you. So just relax. There's something there. We're going to wait. It's how you explain it to the patients. I've done a patient now that had a VAB, 3 months ago. It's just like, just go, have your holiday, come back, go to Europe, that cruise you always wanted. Go on that first, and then we'll come and sort your breast out for you. Lovely. You just explain that to the patient. Wait. I would say wait. Don't go in there when there's a hematoma.
Okay, it's coffee time.
Yeah.
Thanks, everyone.
Thank you very much, everybody.